Welcome to this explainer. If you're a focused learner looking to absolutely master the latest in clinical medicine, well, you are in exactly the right place. Today we're tackling a massive practice-changing update, the 2024 Joint NICE, BTS, and SIGN asthma guidelines. We're going to break down this major paradigm shift in UK primary care into a really clear, visual clinical playbook. It's going to completely upgrade your prescribing logic and, honestly, supercharge your exam prep.
For decades, that classic SABA first, then add inhaled corticosteroids step ladder was the undisputed king of asthma management. But that era, it is officially over. The medical community has completely killed off the secret cow of SABA monotherapy. And if you're taking the MSRA or treating patients in general practice, you need to understand exactly why.
Okay, let's dive into this. Under the old pathway, relying on a short-acting beta-2 agonist, or a SABA, as your first line of defense, basically left the underlying airway inflammation completely untreated. Landmark trials prove that even quote-unquote mild asthmatics treated with just a SABA actually face a much higher risk of severe exacerbations and airway remodeling. The new pathway fixes this by prioritizing early anti-inflammatory therapy right from day one, using as-needed AIR therapy. Examiners absolutely love testing this shift.
So here is our clinical playbook for today. We'll cover the 2024 paradigm shift, the new 5-step ladder, how to upgrade legacy patients, diagnostics and biomarkers, and finally, mastering those MSRA exam questions. Section 1. The 2024 paradigm shift. Let's look at exactly why the medical community made this massive change. The whole core of these new guidelines prioritizes a combination inhaler, ICS and formoterol. Now, why formoterol specifically? Well, unlike other long-acting beta agonists, formoterol actually has a rapid onset of action, just like salbutamol. This allows it to work safely as a quick reliever while simultaneously delivering crucial anti-inflammatory steroid coverage with every single puff. It's a brilliant, unified, single inhaler solution. Moving on to Section 2, the new 5-step ladder. This framework right here is going to be your ultimate MSRA cheat code. To permanently lock this progression into your brain for exam day, we're going to use a super powerful memory hook. Just remember the mnemonic, AIR, M&M's, rules. So you start with as-needed AIR therapy, then escalate to low-dose MART, followed by moderate-dose MART. After that comes a markers check, and finally, referral or trial. Let's walk through those first 3 steps chronologically. Step 1 is as-needed AIR. That's a low-dose ICS and formoterol inhaler taken only when symptomatic. It's perfect for newly diagnosed mild asthma. Now, if they're uncontrolled on Step 1, or maybe they present initially with highly troublesome symptoms like nocturnal waking, we escalate to Step 2, low-dose MART. MART stands for maintenance and reliever therapy, which means they take regular daily background doses, plus extra doses as required, all from the exact same inhaler. If they're still uncontrolled, we escalate to Step 3, which is moderate dose MART.
Section 3. Upgrading legacy patients. What do we actually do with the ghosts of guidelines past when you see patients still on those old regimens? Now, what's really interesting about this slide is the deliberate simplicity of the transition. Your old instinct might have been to just bump up the separate ICS dose or maybe add an LTR. Do not do that. The 2024 guidelines eliminate those fragmented steps entirely. As you'll see, a patient on SABA only switches directly to as-needed AIR. A patient on SABA plus a regular low-dose ICS switches straight to low-dose MART. You're shifting them immediately into these unified single inhaler pathways.
Next up is Section 4, diagnostics and biomarkers. This is where we push right up into the absolute ceiling of primary care at Step 4.
Before we even think about escalating treatment further, asthma has to be confirmed objectively. The diagnostic cutoffs are clearly listed for you right here. For spirometry, bronchodilator reversibility, you need an FEV1 improvement of at least 12% and 200 milliliters. For peak expiratory flow, we're looking for 20% or more diurnal variability. But the 2 absolute most crucial markers you need for your exam are FeNO and blood eosinophils.
50. I literally want this critical number permanently burned into your memory for the exam. For adult FeNO, the diagnostic threshold for elevated markers is exactly 50 parts per billion.
So, the crucial point here is what you do with these markers at Step 4 when a patient remains uncontrolled on moderate dose MART. If either marker is raised, if FeNO is 50 or above, or if blood eosinophils are raised, you must stop stepping up in GP land. You refer them to a respiratory specialist immediately for biologic evaluation. You only ever trial an LTR or a LAMA in primary care if neither marker is elevated.
Finally, Section 5, Mastering MSRA Exam Questions. It's time to battle test all this new knowledge. Whenever you face an MSRA asthma question, I want you to execute this tactical three-step decision tree. First, identify the starting point. Are they newly diagnosed? Are they on a new MART regimen? Or are they on an old legacy regimen? Second, pinpoint their current step on the ladder. And third, actively scan the prompt for red flags, like elevated FeNO or eosinophils at step 4, which immediately changes your answer to refer. Okay, let's try it out. Here's scenario 1. A 28-year-old newly diagnosed asthmatic presents. She has mild intermittent symptoms about twice a week and absolutely no nighttime waking. Based on the 2024 guidelines, what is the most appropriate initial management? Take a second and actively recall step 1. The correct answer is a low-dose ICS/formoterol combination inhaler, taken as required. That's your air therapy. Now, in the exam, a classic distractor is going to be a SABA monotherapy inhaler as required. But as we've established, choosing SABA alone is dangerously wrong under the new rules because it just leaves all that airway inflammation completely untreated. Step 1 is always as-needed air. Let's challenge you with a legacy switch scenario now. A 42-year-old man is on an old plan, a SABA as required, plus a regular low-dose ICS inhaler. Despite excellent inhaler technique and adherence, he is uncontrolled. He's waking up coughing and he's using his SABA every single day. So what is the exact next step? The answer is to switch him directly to a low-dose ICS/formoterol combination inhaler used as MART. The exam will definitely try to trap you by offering options like add an LTRA or increase to a moderate dose separate ICS. Don't fall for it. The guidelines explicitly dictate abandoning that old fragmented approach and switching legacy patients directly over to the unified MART pathways. Okay, finally, let's push right to the primary care ceiling. A 35-year-old woman remains poorly controlled despite perfect adherence to moderate dose MART, which is step 3. Her baseline investigations show a FeNO of 52 parts per billion and raised blood eosinophils. What must you do next? You absolutely must refer her to a specialist in respiratory medicine. Why? Because her FeNO is over 50 and her eosinophils are raised. That indicates underlying type 2 airway inflammation that is simply failing standard inhaled steroid therapy. The major distractor trap here is starting a trial of an LTRA or a LAMA. Do not do that. Continuing to escalate in primary care when inflammatory markers are elevated is only going to delay critical specialist access for advanced biologic therapies. So we've covered the complete shift from that outdated SABA first mentality over to the modern single inhaler anti-inflammatory approach. But as we wrap up this explainer, I want to leave you with a final, slightly provocative thought. If the completely unquestioned SABA first rule lasted for decades in general practice before being proven actively harmful to patients, what other absolute golden rules in primary care are just waiting to be completely rewritten? Stay curious, keep challenging your assumptions, and I will see you in the next explainer.